Hello everyone, I am going to present another video on assignment on Dysarthria supervised by Mr. Indranil Chatterjee, lecturer of audiology and speech language pathology. About dysarthria, we use many muscles to talk. These include muscles in our face, lips, tongues, throat, as well as muscles for breathing. It is harder to talk when these muscles are weak. Dysarthria happens when you have weak muscles due to brain damage. It is motor speech disorder and can be mild or severe. Signs of dysarthria: have slurred or mumbled speech, can be hard to understand, speak slowly, talk too fast, speak softly, not to be able to move your tongue, lips, and jaw very well, sound robotic or choppy, have changes in your voice, you may sound hoarse or breathy, or you may sound like you have stuffy nose or are talking about your nose. Causes of dysarthria. Brain damage causes dysarthria. It can happen at birth or after an illness or injury. Anything that causes brain damage can cause dysarthria, such as stroke, brain injury, tumors, Parkinson's disease, amyotrophic lateral sclerosis or ALS, Huntington disease, multiple sclerosis, cerebral palsy, muscular dystrophy. Types of dysarthria, you can see: flaccid, spastic, ataxic, hypokinetic, hyperkinetic, unilateral, UMN, mixed. Spastic dysarthria is caused by spastic paralysis due to lesions of the upper motor neuron and accompanied by the muscular hypertonia as well as deterioration of strength and precision. Reflectory movements associated with coughing, choking, and swallowing are usually unaffected. Disassociated paralysis as well as movement associated with emotional expression like laughing and crying. Auditory characteristics include strained harsh voice quality, shift to tongue's articulation zones backward, leading to an imprecise production of consonants, hypernasality, as well as slow and monotonous speech. Spastic dysarthria is the most common type of dysarthria and resulting from severe closed head trauma. Rigid hypokinetic dysarthria, damage is located mainly in the basal ganglia. In the presence of an increased background activity, the muscle resistance to passive sketch is increased. Kinesia and bradykinesia are to be found. The voice is weak and breathy, articulation is imprecise, rate of speech may be increased, sounds and syllables iterated. The most common cause is Parkinson's disease, of which is speech disorder counts among early symptoms. Ataxic dysarthria, typical muscular movements are characterized by overshoot or undershoot. Motor efforts cannot be stably maintained. This disorder is caused by damage to the cerebellum and connected areas. As to articulation, there is a tendency toward lenition and fortification. The phonation is hoarse and strained with devoicing, pitch breaks, and instability of pitch as well as loudness. Speech is produced in a syllabic way at a lower speed. The most common causes are inflammatory degenerative disease, cerebellum, and also cerebrovascular damage to trauma this area. Flaccid dysarthria, this is caused by flaccid paralysis following damage to the lower movement motor neuron of the cranial nerve of the brainstem, but also be observed after suprabular lesions. Symptoms are reduced muscle tone, loss of voluntary and reflectory functions, muscular atrophy, and possibly fasciculations, often concern single muscles only. The damage result depending on its localization in a weak breathy voice, hypernasality, imprecise consonants, and a decrease in speech rate. The most frequent cause of flaccid dysarthria is damage in the brainstem, e.g. in cases of amyotrophic lateral sclerosis, but also peripheral nerve damage occurs as polyneurotrophy tumors. Damage of the neuromuscular junction occurs in the myasthenia or muscular diseases lead to symptoms of flaccid dysarthria. Dyskinetic or dystonic type of dysarthria, inappropriate muscle activation patterns with hypertonic contractions and uncontrolled movement can also affect the muscle involved in speech production. This can lead to varying impairments of voice quality, to interruptions in speech flow, or to the involuntary vocal output as observed in Huntington disease or in athetosis. Spasmodic dysphonias or oromandibular dysphonia result from formal vocal dystonia, tremor, and myoclonus, which can cause phonatory as well as articulatory disorders. Belong to the group of sorry repetitive hyperkinesis with a variety of frequency, amplitude, and acceleration patterns. Diagnosis: assessment of speed, strength, range, accuracy, coordination, and steadiness of monospeech movements, and assessment of the speech subsystem using objective measures are available. The following are typically included sorry completion of cranial nerve exam to assess facial, oral, veropharyngeal and laryngeal function of symmetry, observation of facial and neck muscle tone at last and during non-speech activities, assessment of sustained bile production to determine if there is adequate pulmonary support and sufficient laryngeal valving from phonation, assessment of alternating motion rates and sequential motion rate or diadochokinetic rates to judge speed and regularity, jaw, lip and tongue movement, and to lesser extent articulatory precision. Speech production, vocal quality and ability to change loudness and pitch to assess laryngeal or phonation function, stress testing 2 to 4 minutes of reading or speaking aloud to assess deterioration over time, motor speech planning and programming, repetition of simple and complex multisyllable words and sentences to determine apraxia of speech is present. Prosody, use of variations in pitch, loudness, duration to convey emotion, emphasis, and linguistic formation. Speech neutralness reflects prosodic accuracy. Recommendations for speech sampling include the following: use connected speech, reading, and spontaneous speech to observe variation in pitch, loudness, duration. Use targeted prosodic tasks, include asking the answering questions, contrastive stress talks, and reading statement using prosodic variation to express different emotions. Speech intelligibility, the degree to which the listener, familiar or unfamiliar, understands the individual speech, typically reported as a percentage of words correctly identified by listener. Recommendations for speech sampling include the following: use material unknown to the listener and with low semantic predictability, include words that provides a sampling of most of the phonemes. Tasks include single word production and sentence production. Comprehensibility, the degree to which listener understand the spoken message given other informational cues to enhance communication, typically reported at percentage of words correctly identified by a listener. Materials and tasks are similar to those used to assess speech intelligibility. Various cues, auditory, visual, contextual, and provided to the listener. The speaker's use of comprehensibility strategies or the potential to adopt these strategies can also be addressed during these tasks. Efficiency, the rate at which intelligible or comprehensible speech communicated, typically reported as the number of the or the comprehensible words per minute. Sentence level materials and tasks are similar to those used to assess speech intelligibility and comprehensibility. Sentences are transcribed by a judge and number of correct words per minute are computed. Treatments are grouped into those that directly target the speech production subsystem and other treatment options including communication strategies, environmental modification, alternative argumentative and alternative communication, that is AAC, and medical surgical intervention by other specialists. Treatment selection depends on the number of factors: the severity of disorder, national natural history and prognosis of the underlying neurogenic disorder, the perceptual characteristics of the individual speech and his or her communication needs, patients and family presence, preference and engagement, and the presence and severity of co-occurring condition, etc. Aphasia, cognitive impairment, apraxia of speech. One or more these co-occurring conditions might affect the individual insight into communication limitation. Ability to implement compensatory strategies such as conversational repair or ability to benefit from some treatment approaches. It can be important to sequence treatments. For example, respiration and phonations are usually targeted initially, but prosthetic management of velopharyngeal dysfunction may be needed first in order to achieve efficient and effective breathing phonation of speech. Treatments are targeting speech production subsystems. Respiration, making postural adjustment, sitting upright, improvement breath support for speech, inhaling deeply before onset of speech utterance, known as respiratory inhalation, using optimal breath groups while speaking, can use using expiratory muscle strength training to improve strength of expiratory muscles, using inspiratory muscle strength training to improve strength of inspiratory muscle to permit better sustained or repeated inspirations, using maximum vowel prolongation tasks to improve duration and loudness of the speech, using controlled exhalation tasks to improve controlled exhalation of speech, using non-speech tasks to improve subglottal air pressure and respiratory support. Phonation, an intensive program that targets high phonatory effort to improve loudness and intelligibility. Pitch limiting voice treatment, A program for increasing vocal loudness without increasing pitch, effort closure techniques to increase abductory forces of vocal folds, improve timing of phonation. Articulation, phonetic placement techniques, hands-on descriptive pictures to work on positioning of the mouth, tongue, lips, jaw during speech, phonetic derivation techniques such as blowing to you, exaggerated articulation, over-articulation to emphasize phonetic placement and increase precision, sometimes called clear speech, minimal contrast to emphasize sounds contrast necessary to differentiate one phoneme from another, intelligibility drills in which individual reads words, phrases, sentences and attempts to repair content not understood by the listener. Rate modification to facilitate articulatory precision strategies include pausing the natural linguistic boundaries, using external pacing methods such as pacing boards, finger tapping, alphabet boards, using auditory feedbacks, using visual feedbacks, using approaches that reduce speech rate, directly targeting. Resonance prosthetic management in collaboration with other disciplines. Example include parallel lip prosthesis and nasal obturator to occlude nasal airflow. Prosody, increasing awareness and ability to control respiration rate and pitch to vary emphasis with multisyllabic words in connected utterance. Improving intonations by signaling stress with louder pitch or duration. Extended breath groups to better align with syntactic boundaries using contrastive stress talk to improve prosody and naturalness. Thank you.